hope everyone's safe and warm wherever they are and have no issues with roads today. I know they've been rough. Today we're going to talk about surgical site infections. And we're very happy to welcome Rochelle Beard, who is our new infection preventionist, and she's going to do a little bit more of an introduction of herself shortly. But this is Deb Campbell, Vice President of Quality and Health Professions at KHA, and I know many of you. Talked about Rochelle. Dolores Hagan is our quality data analyst. Emily Henderson is our pharmacist consultant. Charlie Kendall is our external liaison, mostly working on transitions of care. Melanie Mock is Vice President of Data and Health Information Services, and many of you may not yet have met Kayla Rowe, who's our Community Outreach Coordinator and working mostly with Charlie, Emily, and Melanie on the community's work we're doing. So that's our team. Wanted to recognize that while this is a general KHA quality webinar, the content fits into many of the things that we're doing. For example, within our Rising Stars program, for those of you participating to improve your CMS star ratings, certainly this is part of the patient safety area. Also works very well to, if we get rid of those SSIs, we can prevent some sepsis cases, obviously, in the hospital onset sepsis, post-op sepsis, obviously is part of the measures that we collect already. And indeed, the newest probably to all of you is the iPro HQuick contract that we are participating in, and it's kind of the new HIN world for those of you participated in that. And the HAIs are part of that work as well. So what we do with this area of harm will help us in all of the initiatives that we're involved in. And any data that you give us, as most of you have been for years, will flow seamlessly into any project for which it is a measure. So we just wanted to let you know that. And now I'd like to go ahead and introduce Rochelle, who's going to talk a little bit more about her introduction and then go right into SSI. Rochelle?
Thanks, Deb. Can you hear me?
Very well.
All right. So first of all, I just want to introduce myself to everybody. I know a handful of you guys in the Louisville area, but my name is Rochelle. I'm an infection preventionist. I have just been at Kentucky Hospital Association for just around a month. Prior to that, I was infection prevention at an acute care hospital for around 16 months. And before that, I did 4 years of infection prevention, quality improvement, and employee health at a pediatric long-term care facility, along with a variety of other programs at a facility we have in Louisville. I'm the current education outreach chair of our Kentuckiana APIC chapter. And before I jumped into infection prevention, I did around 7 years of pediatric bedside nursing. So today we're going to talk about SSIs, and as Deb had mentioned, SSIs impact a variety of different aspects, whether it be readmissions or sepsis or antibiotic stewardship. So we're just going to talk about what the impact SSIs have, talk about NHSN a little bit, but mainly explore the guidance and all the best practice information for SSI prevention. We're going to dive in a little deeper for colon and hysterectomy surgeries, but a lot of the things I'm going to share with you apply to all surgery cases, not just colon and hysterectomies. Got a lot of examples and different tools and methods and best practice suggestions throughout the presentation as well. Before we dive in, I will say that if you have any technical difficulties, Tammy Wells has the chat open where you can message her to kind of troubleshoot anything, and then we'll have a time for questions about 10 minutes at the end of the presentation. So what is an SSI? I have the CDC's definition right here. An SSI is an infection related to an operative procedure that occurs at or near the surgical incision within 30 days or within 90 days if there's prosthetic material implanted at surgery. So this is where you have your colon and hysterectomy surgeries that you review for 30 days, and then your hips and knees that you looked at for a 90-day period. So why do we even care about SSIs? SSIs obviously pose a significant risk for morbidity and mortality with a mortality rate of 3%. It is a leading cause of post-op readmissions. And then it costs a whole lot of money. So if you look down here at this $11,000 to $42,000, this is in addition to a normal readmission. So if your average hospital stay is roughly $12,000, this $11,000 to $42,000 is on top of that already $12,000 cost. So you're looking at up to $54,000 for a post-op SSI readmission. Wanted to talk a little bit about NHSN. NHSN is the National Healthcare Safety Network. It is the CDC's infection tracking system. Wanted to kind of talk about it because why do we care about submitting data to NHSN? How does it help us, etc. So NHSN helps provide the data that's included in there, helps give guidelines, best practice, targeted education, provides baseline benchmarks, all those kind of things. So, but those guidelines and those benchmarks are only as good as the data and information that's being submitted. So for example, let's take like hip surgeries and SSIs that are secondary to hip surgeries. So they're not a CMS mandated reportable infection. So you may not be reporting those to NHSN, but the hospital down the street is reporting them. And guess what? They haven't had a hip infection in years. So according to NHSN, it looks like the state of Kentucky doesn't really have any problem with hip infections because the only hospitals reporting on hip SSIs are ones that don't have any hip SSIs. So we're not going to get funds based on for hips SSIs. We're not going to have education because nobody knows that we actually have a problem with hip infections. So it's kind of like if you just rely on the ones who make no mistakes providing the information, it's kind of like in nursing school when you had that person who always just ruined the curve for everybody in the class. I was definitely not that person. I was one of the people that was impacted by the person who scored super high and skewed the curve for everybody. So you want to be able to submit information and data when you can, because then you're able to mold what the benchmarks are and actually provide an accurate picture for what the data is that we're looking at. I just kind of wanted to summarize in here a little bit of the information that NHSN's reports show. So there was a 7% decrease in the standardized infection ratio, the SIR, related to the NHSN procedures between 2015 and 19. So that's great. And then also showed a 9% decrease in the SIR related to SCIP protocol, the Surgical Care Improvement Project, which I will talk more about SCIP a little bit later. To note, I did not include SIRs in these graphs here. This is Kentucky data for colon and hysterectomies. Again, to remind you guys that this information is only as good as who submits it. And then also a caveat that obviously December 2020 is not completed yet. So that will change, those numbers will change in the future, but I did want to go ahead and include it on there. So we have more colon infections than we do hysterectomy infections, which makes sense just based on the nature of the procedure. On your left, you've got 2019, and on your right, you've got 2020. We look slightly improved in 2020, but we all know 2020 is not exactly the year we want to look at to set baselines or benchmarks. So for the different initiatives at KHA, we are going to be looking at 2019. Just to note, if you look at April of 2020, hysterectomy SSIs jumped up, which makes total sense when I look at the numbers because the denominators drastically dropped. So you were still having a similar infection rate, that same amount of infections, and your rate's going to go up because your denominator drastically dropped because we were canceling elective procedures. So that makes total sense. Sorry, the slide stopped moving. Okay. So now I'm going to get into the meat of the presentation, and this is going to be our guidelines for SSI prevention. So this is based on the Wisconsin Department of Public Health's recommendations, their guidelines. The way this is kind of structured is HCPAC, which to remind everyone is the Healthcare Infection Control Practices Advisory Committee. HCPAC came out with these guidelines in 2017. And then shortly after, later in 2017, the Wisconsin Department of Public Health built upon that framework that HCPAC provided. And so they kind of get more specific than HCPAC does in some situations. So I will focus in on the ones that are the more specific, which tends to be the Wisconsin Department of Public Health, which is the WDPH. So this is where I was talking about it applies to all surgery cases, not just our hysterectomies and colon surgeries. These are guidelines for all surgeries and preventing SSIs no matter what. Another thing I wanted to bring attention to was the category 1A and 1B recommendations that you'll see reflected in the HCPAC side of the table. And this is just how the CDC does the strength of their recommendation. So 1A is a strong recommendation that's supported by high to moderate quality evidence that suggests net clinical benefits or harms. And then 1B is a strong recommendation supported by low quality evidence that suggests net clinical benefits or harms. But it can also be an accepted practice that is supported by low to very low quality evidence. So that's what you'll see the majority of the time is either 1A or 1B. So to get started, antimicrobial prophylaxis. Looking at 1 and 2 right here, it is talking about administering your antimicrobial agents as indicated and based on clinical practice guidelines. So your antibiotic selection is typically going to be like your penicillins, your cephalosporins, other related compounds, beta-lactams, those kind of things. And then number 2, you're looking at administering the appropriate med prophylactically before your skin incision. This says in C-sections, but in all cases, within 60 minutes prior to cut, you want to have your meds infused. Sometimes this is easy, sometimes it's not. Sometimes you have more antibiotics that you have to give, some have to be given over a longer time. So it kind of can become hard to juggle sometimes. So look up your fastest infusion time. Can this med be given over a couple minutes? Can you give these 2 antibiotics together? Try to figure out how you can fit in the puzzle pieces to get your antibiotics in. Number 3, talking about following the American Society of Health System Pharmacists guidelines for antibiotic dosing. So if you have a patient with a BMI under 30, it's going to be 2 grams of a beta-lactam, and if it's over 30, 3 grams of a beta-lactam. Number 4 talks about antibiotic redosing. So HCPAC, as you see, doesn't really give any guidelines, but Wisconsin says to base your antibiotic redosing based on the antibiotic's half-life and then also the duration of the surgery. So if your surgery is going longer than was planned and you were planning on redosing antibiotics, but now you have to, they recommend going ahead and doing that. And then number 5 talks about not giving another antibiotic prophylactically while you're still in the OR after closing. And then number 6 is more specific to colons, and it's talking about oral antibiotics with a mechanical bowel prep. And I'll talk about that in more detail a little bit later. Next is glycemic control, which, speaking from experience, this always seems to be a struggle to get accurate glycemic control, whether it be orders or treating. It seems to fall out a good amount of time on a variety of cases. So all 3 of these, we're going to look on the Wisconsin side. You want to maintain a perioperative blood glucose under 200. Some places go even lower than that. Number 2, to avoid the increased risk of hypoglycemic events, they tighten this to keeping blood sugars between 81 to 108. And then number 3 focuses in on optimization. So getting your hemoglobin A1C less than 6.7. So I'll talk about this again a little later with ERAS, but optimization is really just getting your patient set up so they can have the best outcome. So if you're doing an elective procedure on a patient and you really can't get a hold of the A1C, maybe you delay it a little bit until you can get control of that A1C before surgery so they can have help with healing. I told you that I've witnessed glycemic control be kind of a struggle. One example I've had is we had a surgeon before who's done a surgery on a case on a Friday. So surgeon does the case on the Friday, patient's admitted, surgeon goes home, passes off the information to the hospitalist or the resident, whomever's watching the patient over the weekend, doesn't come back to visit the patient until Monday, or the patient already is discharged. So they forgot to write post-op glucose monitoring orders. Nursing doesn't notice, none of the residents or hospitalist doesn't notice. So that patient went all weekend without having any glycemic monitoring. How can we prevent this? So there are couple different ways that you could look at this. Could potentially make post-op order sets. Are there specific surgeries you can go ahead and have generic post-op order sets that include having the glycemic monitoring orders? Or this particular unit that had this happen, the nurse manager created a nurse checklist for post-op checklist for nursing to look at to see all the things they needed to follow up on when they got a post-op patient. So do they have glucose control orders and monitoring orders, diet orders, ambulation orders, wound care, those kind of things. So just to kind of think to try to, how can you prevent this from happening again in the future? Moving on to normothermia. So just overall, you want to maintain perioperative normothermia. So 36 to 38 degrees Celsius. And then number 2 here talks about considering the use of forced air warming. So it references a study that shows that forced air warming reduced the incidence of SSIs and complications in patients with abdominal surgery. But then down below, it kind of talks about how sometimes there may be an increased risk for intraoperative wound contamination if you're doing ortho cases, but then it also says there's not any actual clinical correlation that they can for sure relate. So just consider the use of forced air warming to help maintain your normothermia. Another thing you can do, you can use fluid warmers, bear huggers, ensure your thermometers are working correctly. There's nothing more annoying or embarrassing if you didn't do it than like if you call IT and you're like, oh, my computer's not working. And then they're like, did you turn it off and on? That's kind of like the equivalent of, oh, your thermometer wasn't working. So make sure your thermometers are working. If you're getting kind of crazy numbers in your OR, go ahead and make sure your thermometers are working. And that's an easy fix if that's all it is. So moving on to oxygenation. So this just talks about for patients who have normal pulmonary function and are intubated, administer increased FiO2 during surgery and after extubation in the immediate post-op period. Kind of just straightforward there. Antimicrobial prophylaxis. So this is talking about your CHG treatments preoperatively. So number 1 talks about doing your CHG prep, the 2% CHG with 70% alcohol on the incision site when you're in the OR. Number 2 talks about doing your CHG showers or your bathing with the CHG wipes, so the 4% or 2% as appropriate. Down here, number 3 goes into talking about standardizing the process of doing the CHG showers or wipes. I'm not going to go into that. You can read that in that lovely document, but it's a good idea. So you know there's step-by-step instructions and you really help to prevent failure if they know how many wipes they're supposed to use or they're supposed to use the whole bottle for their shower, etc. Some more on the antimicrobial prophylaxis. HICPAC talks about considering the use of the triclosan-coated sutures, and you'll see here that they noted as a category 2, which is actually documented as a weak recommendation supported by quality evidence that kind of says, it may help, it may not. But Wisconsin says to actually use triclosan-coated antimicrobial sutures, and they reference several clinical trials and reviews and meta-analysis that have determined that the use of these sutures actually represent a category 1 clinical evidence in preventing SSIs. So recommendation for using triclosan-coated antimicrobial sutures. And then the last one just says to not apply antimicrobial agents, different ointments or powders onto the surgical wound in an effort to prevent an SSI. Another thing I did not include on here, it's also documented as a category 2, just talks about considering the use of intraoperative irrigation with that aqueous CHG. So staphylococcal surveillance, this was not included at all in the HICPAC guidance, but Wisconsin Department of Public Health had a whole section on this. It's a hot topic in Kentucky, and it can definitely be useful to prevent MSSA and MRSA infections. So a couple ways that you can do this. You can add nasal mupirocin 2 times a day for 5 to 7 days preoperatively, or you can also swab the nares with 5 or 10% povidone iodine the morning of surgery. To note, both of these interventions are in addition to your 2 CHG showers or bathing treatments with the wipes. So as I mentioned, practice varies throughout Kentucky. I know there are some hospitals that are implementing in surgery patients and some in ICUs for doing your nasal decolonization, but you should really choose your method and your screening based on your facility's risk assessment and their risk of MSSA and MRSA infections. So this is not just, do you have MRSA infections in your SSIs, but are you having MRSA and MSSA infections in your other HAIs? Are you having CLABSIs that have these staph organisms? So take that into consideration when you're trying to decide if you want to do anything related to this. You can do targeted screening pre-op suppression for MSSA and MRSA colonized patients who are having at-risk procedures, such as cardiovascular, other vascular procedures, and procedures with prosthetic grafts or total ortho joints. All right, gonna dive a little bit into the specific colon and hysterectomy infection prevention. Not too long, so those who don't have them, don't zone out. So some of the best ways to prevent SSIs with these cases are to put your interventions into bundles. So there's a study that showed a 35% reduction in colon SSIs simply after implementing a colon prevention bundle. I talked about oxygenation earlier. This is specific to colon procedures. So talks about using high O2 supplementation during colorectal cases, so an 80% FiO2. And during a peri-op period, it showed reductions with colos, but did not actually show a reduction in SSIs for other cases, just colons. You can use a wound protector, have that as part of your bundle, and that's what that picture is right there. The purpose of a wound protector is to reduce wound edge contamination, but you need to make sure it is used correctly, because just as easily as that can help reduce your wound edge contamination, you do that wrong and put it in incorrectly, then it can make it way worse. So make sure that you use the wound protector appropriately. And the different vendors have videos on how to use it and guidelines and all that to help you make sure to do it correctly. You want to do oral antibiotics in combination with the mechanical bowel prep. So there's a study in Spain that was published in The Lancet in April of 2020. They did a randomized controlled trial with oral antibiotics the day before surgery, and they did not use a mechanical bowel prep in this study, but on patients with a colon resection or colectomy. The incidence of infection was 11% in the group that did not have antibiotics and 5% in the group that did receive antibiotics. And they did Cipro and metronidazole. Just to note, I do know that sometimes oral antibiotics are contraindicated, and sometimes colons can be emergent and you may not have time for the mechanical bowel prep. Obviously, we know those are outliers and sometimes unavoidable, but best practice is to do your oral antibiotics and mechanical bowel prep preoperatively. I just wanted to note, separate closing tray and glove change for closing of fascia and skin. It has been included in some bundles that I've looked at and is in my example on the next slide. So this is an example of a colon SSI prevention bundle from Reese et al. They used this bundle and they saw a non-significant decreasing trend of 0.5 SSIs per 100 procedures over a 2.5-year project period. They noted 60 to 80% bundle compliance, and that their top 3 most important interventions were appropriate skin prep, wound protector, OR staff glove change before fascia. They did recommend that and say that they possibly would have had more success if they had implemented fewer interventions. So then, or fewer bundle components, because then they would have had better compliance, they thought. So one thing to think of if you do not currently have a colon SSI prevention bundle, I know on this call we have people all over the spectrum. maybe consider implementing fewer interventions than what is included here. So then you can get your buy-in, you can get your participation, you can get your compliance, and once you are solid, you can move on and add more. So focus in on maybe the ones that are strongly recommended, like the bowel prep or and antibiotics, those kind of things. A little bit about hysterectomies. Once again, you can put everything into a hysterectomy prevention bundle. I have a fantastic example on the next slide. I did want to note on here a separate closing tray and glove change for closing of fascia and skin. I will note that although this is included in a decent amount of facilities, hysterectomy or even just gynecologic bundles, it's really hard to find a lot of evidence-based, really strong evidence for this, because it's normally included in a study that is studying the effects of a complete bundle and not this specific intervention. So I've looked into this before, and although it sounds great, it is really difficult to find a cause and effect with this specific intervention. But it is included, and it is included in the example that I will show you. You want to clip hair, you don't want to shave the incision site because you don't want to risk skin breakdown, and then look into maybe a clean and dirty setup. So have separate instruments when you're going between the abdomen and the vagina. So this bundle was in a study done by Davidson et al. In the American Journal of Infection Control. This hospital, they do about 300 hysterectomies annually. Their hysterectomy quarterly SSI rates were often in the 75th percentile in NHSN. They looked into OR ventilation, OR traffic, instrument sterilization, antibiotic redosing, and sterile technique, and somehow they couldn't find any issues with any of those. So they created a multidisciplinary task force, took about 6 months to create their bundle. And then they divided their bundle elements into pre-op, intra-op, and post-op, which is the framework of a fantastic bundle. They did a retrospective cohort study, and they divided the women into pre and post-bundle groups. The pre-bundle SSI rate was 6.18, and the post-bundle was 2.51. So an over 4% decrease in their infection rate, which is great. So I wanted to highlight this section of their bundle because I really, really like it. This is all just their pre-op bundle. So you'll see here they divided their pre-op bundle into their pre-op clinic visit. They talk about just the generic risks of having surgery. They go into the A1C, so the optimization we talked about. They encourage smoking cessation, which is also optimization, and then talk about no shaving the surgical site. Then they have the pre-op anesthesia visit, and they talk about the CHG cleaning. They reiterate not to have any shaving. Then you go into the pre-op holding or in the PACU. They talk about your normothermia, CHG wipes, checking your blood glucose then. And then I didn't include the example on here, but wanted to talk about it down in their intraoperative. They talk about surgeon antisepsis. They also talk about giving the antibiotics, your skin prep, again, talking about clipping instead of shaving. They even talk about OR attire. They also touch on normothermia again, anesthesia, checking blood glucose at certain times throughout the procedure, and then their closing protocol, which they do touch on the glove changes and instrument change, limiting OR traffic. Post-op, again, maintaining glucose control, and then they have their wound care orders and discharge education and follow-up phone calls. So a very, very thorough bundle. And in the resources, I have this article information so you all can reference this as well. So we want to look at some process measures. What is a process measure? So the Agency for Healthcare Research and Quality, AHRQ, defines a process measure as a measure that indicates what a provider does to maintain or improve health. This typically reflects a generally accepted recommendation in clinical practice. So an example would be like the percentage of people who receive preventative services, such as mammograms, flu vaccines, SARS-CoV-2 vaccines. Those are considered process measures. So a couple of process measures you can look at are your hand hygiene rates. So what are your hand hygiene rates? What are your misses? What groups of people are falling out? Are you using gloves as a substitute for hand hygiene? Nobody does that anywhere. But what are your fallouts and what do you need to target based on that process measure? Are you following your surgical care improvement project, your SCIP protocol? What percentage are you having fallout on your antibiotics? Are you maintaining your glucose control? Are you getting your antibiotics in before the incision? Are you discontinuing your antibiotics within 24 hours of the case? Are you shaving or are you trimming? Why are you falling out? And then once you've identified who or what's falling out, what are you doing about that? Are you educating? Are you doing root cause analysis? Are you addressing the issue that's causing you to fall out? How are you addressing it? And then what are your immediate use sterilization fallouts? How often are you flashing instruments? Why are you flashing them? Is it just because you don't have enough instruments for the volume of cases you're doing? I like to say that's a relatively easy fix. It's a costly fix, but is that simply the reason why you're having to flash instruments? So some best practice interventions, these are just going to be different examples that I've found throughout my research and then also through different experiences and stories I've heard from colleagues. So a couple examples up here. So you could pre-populate your discharge instructions or your after visit summary. So in order to help prevent SSIs, you want to make sure that the patient gets the appropriate information. So one way to help assure that is never forgotten, if you have an electronic health record, go ahead and pre-program your post-op instructions for as many surgeries that you can. If you can do it for hysterectomies, colons, hips, knees, or if you have even generic post-op instructions that you can use for any case that can apply to any wound care, go ahead and do that. I talked about earlier the nursing checklist for your post-op patients. That's something you can do as well. And then I talked about the electronic health record. If you don't have an electronic health record, you can still pre-make your post-op instructions. You just may not be able to pre-program them into a computer, but you can create them and have a document that is given to your patients that is going to look the same for everyone that has that specific surgery. Maybe do some focus on teach back, show back, and then make sure you document that they taught or showed you what they learned. So we all know this situation. You have a patient, you go in, teach them how to do their wound care, and then you're like, you got it? And they're like, oh, yeah, I get it. Did they really? Who knows? We won't know until 3 weeks later they show up with a superficial SSI, and then, oh, maybe they didn't know. So whenever you focus on teach back or show back, well, you can walk the patient through or demonstrate and have the patient either perform the wound care themselves, or they can walk you through it verbally so then you know that they've actually retained the information and understand how to implement it. And then again, document on it, because if it's not documented, we know it wasn't done. So ARC has their CUS program, Comprehensive Unit-Based Safety Program, and this combines improvements in safety culture, teamwork, communication. They have checklists for evidence-based practice, and their focus projects right now are CLABSI and CAUTIs in ICUs. They also do SSIs and antibiotic stewardship. The great thing about this program is they have a lot of toolkits and they're modifiable to be able to tailor to your specific facility or unit's needs. Another thing that I've recently been brought to my attention, the Improving Surgical Care and Recovery, ISCR. This is a surgical quality improvement program that's funded by ARC. It's in collaboration with the American College of Surgeons and Johns Hopkins. This program helps support hospitals to implement perioperative evidence-based practice pathways to help improve your outcomes, reduce hospital stay, and help improve the overall patient experience. Hospitals can participate across colorectal, orthopedic, gynecologic, and emergency general surgery service lines. This program started in September of 2020. It's 18 months, and they have coaching calls, subject matter experts that you have access to, nurse consultants, tools, a variety of educational materials. And then there's enrollment information on the website, which I've also included in the resource list at the end. I was on a call, one of their coaching calls earlier this week, and it was fantastic. This hospital was talking about their prehab, not rehab, but prehab education that they did prior to a patient having surgery. One of the coolest things I just thought was just so simple and just great, was they talked about how they educated on and practiced the log roll to stand maneuver. So they had patients do this 5 times a day leading up to their surgery. I'm not sure on how many days. I think it kind of depended on when their pre-op visits were or if they were in the hospital. But they had to practice it 5 times a day so that whenever you're trying to get them up on post-op day 1, then you're not having to teach them how to log roll, sit to stand. They've already known it. They're masters at it because they've been practicing it 5 times a day for however long. I thought that was great and very simple. And then one of the things they also did pre-operatively and set that goal for post-operatively, having them walk 5,000 steps a day. And this facility did provide them their own step trackers if they needed one, but you don't have to get all that fancy. Recommend 5,000 steps a day. ERAS, Enhanced Recovery After Surgery. So ERAS is patient-centered, evidence-based practice. Team-developed pathways to facilitate recovery and optimize a patient's physical function. So some key elements are patient and family education, patient optimization with the smoking cessation, weight loss, maintaining a lower level of A1C, getting that all taken care of before you have the surgery and considering a delay of surgery if you can't meet those goals yet. This hospital also offered a Chantix prescription to people who are smokers in their pre-op appointments prior to surgery to help get them to stop smoking before they had their surgery. Minimal fasting, so you get a carb drink 2 hours before anesthesia. Using a variety of analgesic interventions and not just jumping straight to your narcotics or your opioids. Music, using a comfort menu, lights, all kinds of different things instead of just going straight to the narcotic prescriptions. So returning to normal diet and activities the day of surgery, get out of bed to that chair, and then return home as soon as possible. Some other things to do: OR observations and perform gap analysis when you do your OR observations. You want to look at hand hygiene, your OR traffic, your opening and door closings. So I have a not so lovely story of a case that I watched before in the OR, specifically to hand hygiene. So we had a circulator who had her gloves on and was on one side of the OR, and she would type on the computer, etc., walk over, collect the bloody gauze, count them, mark it on the board, mark something on the clipboard, and then walk back to the computer and change her gloves and then document on the computer. No hand hygiene whatsoever, just changing gloves. So obviously using gloves as a substitute for hand hygiene. I'm going to say half on her, half on us for not having all the right tools for her. She did have a hand sanitizer unit on the wall by her computer, but there was not one on the other side of the OR where she would have been counting the gauze pads. So even if she wanted to, she didn't have the option to take off her gloves and do hand hygiene right there before she documented on her board. So that's something, pay attention to where your hand hygiene units are within your ORs. And if people are using gloves as a substitute. Another thing I observed, which I'm sure nobody else has ever seen, was anesthesia not doing hand hygiene at all. This CRNA touched her Cisco phone, touched her glasses, her scrub cap. And then the thing that made me cringe the most was when she assisted the scrub tech to pull back the patient's abdomen to help put on a dressing. No hand hygiene, no gloves, nothing anywhere in there. So you don't know what you're going to find in your OR until you actually walk into your OR and watch. Sometimes you'll be pleasantly surprised and sometimes not so pleasantly, but still surprised. And then once you do, another thing you can look at is OR traffic. Are people taking breaks when they shouldn't? Are you relieving people? Is the door opening and closing? What's going on there? And then once you identify an SSI, do a case review. Make this multidisciplinary. Involve your surgeon, your infection preventionist, your OR and nursing leadership, anesthesia, because they can help with the antibiotic redosing component. And you can talk about hand hygiene, educators, quality department, anyone you can think of that can help prevent an SSI from happening in the future. You really want to use these meetings as times to think outside of the box. Another experience that I had in one of these meetings, while we were discussing a C-section infection, and we were really trying to think of ways to help prevent this in the future. The labor and delivery nurse manager was like, you know, I got my eyebrows microbladed before, and they gave me this cute little handout that gave step-by-step, easy to understand instructions on how to take care of my eyebrows. Why can't we do this for our moms who have C-sections? So lo and behold, that's what they did. They made a cute little card with the wound care instructions that matched what is in their discharge instructions that they are given when they go home with all their normal paperwork. But it's in a cute little bag with a little bottle of Dial soap, and it's in a nice little, I think it was like a pink or purple satchel, so that it was separate for the mom. So it also is kind of like, hey, take care of yourself, clean your wound. And it's kind of looked at something as like pampering and not just as all these dreaded post-op directions we have to follow. So really just think outside of the box.
I gotta pee.
So, I'm sorry?
Oh yeah, I know, I don't want to get my car dirty.
I think someone's off mute. If you could go ahead and mute your line, please. A couple other things to think about. So OR attire, scrub caps are always going to be the bane of every infection preventionist existence. Scrub caps, are your OR scrubs clean? What's the jewelry look like in the ORs? Is it really overabundant? Are people wearing fake nails? And then another thing to think about with scrubs, obviously a lot of our surgeons have rights at our own facilities and then also the facility down the street. They're going to their office. So are they changing scrubs when they're coming into your facility, or are they wearing the same scrubs they wore at the facility across the street when they did surgery? And then something that we didn't have to even worry about a year ago is with universal masking. Same thing. Are they changing their mask when they come into your building? Are they changing their mask when they go into your OR? Something to look at that we never had to really look at before. Just some other things. Look at your OR cleaning, your HVAC, your air exchanges. Is your positive pressure working in your ORs? Do you have construction going on in your ORs? Are the construction workers following your ICRAs? Did you even know about that project going on in the OR? So is there even an ICRA? So pay attention to that. Another thing would be, are rehab facilities following your wound care instructions? Do you notice a trend in patients that are admitted to certain facilities? Look in to see if your wound care instructions are just landing in the trash when they go there. Does your team or your facility know how to perform a root cause analysis, and are they doing them? So I kind of talked about earlier about the OR traffic. And one intervention with OR traffic, they recommend like putting a sign on the door so people have to sign in and out. So let's say you do that because you have an OR traffic problem, but then your OR traffic still exactly the same. Did you really find the cause for that? Maybe the cause is because you're short-staffed and your charge nurse has to go in and circulate and people have to ask her questions, or perhaps the phone isn't working and they can't just call the phone to ask questions, so they have to go in the OR. So you have a staffing problem, or do you have a technology problem? Is there just no signal on the phone? Different kind of things. Keep asking the why on your root cause analysis. Don't just throw an intervention at it to try to appease the problem. Really drill down, go why until you can't have a why anymore, to find out what's causing your problem. Why does that door keep opening in your OR? So just wanted to lastly tie this all up in a pretty little patient and family engagement bow. So patient and family engagement is collaborating with patients and families of all ages at all levels of care and in all healthcare settings. Families, however they are defined, underline that, are essential to a patient's health and well-being. So this is really just saying, hey, a patient's family is who they say their family is. Whether it be their parents, whether it be their significant other, their cousin, their best friend, their neighbor, whatever. If a patient says that's their family, that's their family. I wanted to mention CUSP again here. So CUSP was developed after an 18-month-old died from dehydration and inappropriate narcotic use. So ask your families and your patients about their concerns and ask them for questions. Thank them for allowing you to take care of them, and then understand that they really feel out of control, and there's a lot of stuff they can't control. So give them an opportunity to regain some of that control when possible. So I told you earlier that I did bedside pediatric nursing prior to infection prevention, and I worked on a med surg floor that had a lot of post-op patients. And you obviously want your kiddos to start drinking pretty soon after surgery. Well, kids aren't really like, oh yes, let me drink a bunch of water. So we had slushies available. So instead of being like, hey, are you thirsty? Do you want to drink? Go in and I'd be like, hey, we have a red slushie and a blue slushie. Which color would you like? So you're still giving them control when they ultimately feel out of control. So they get to make a decision when possible. Pre and post-op bundle elements. So a lot of your education is going to happen in the pre-op and post-op period. So make sure that you make it a comfortable setting, an open environment, sit down, whether it's you providing the education or the surgeon, take some time, have a seat, because that helps promote an environment of ease, and the patient and family member doesn't feel like you're about to run out of the room to go do all the 100 other things that we all know you have to do, but promote an environment that they feel comfortable asking questions. Overall, this will help improve your outcomes because patient and families feel heard, they feel included in their plan of care, they're able to take ownership because they feel like they were part of the plan. And then you could also identify some potential barriers for healing or post-op care. So let's say you're chatting with the patient and you find out they live in a bi-level, and the only way to get up to their bedroom is to go up a flight of stairs. They may be having a surgery that you really don't want them to go up a flight of stairs. So how can you fix that? And how can you address that before you actually have the surgery instead of trying to scramble and fix the problem after the fact? Or with NTI, if a patient has no childcare to take care of their children who are at home doing virtual learning, they may just kind of disregard their own post-op care to focus on their children. So how can we set something up so that they can do the best for themselves, but still also feel like their children are taken care of? So these are things that you, by promoting an open environment, you can really get into some of these things that you can fix before the surgery has even happened. So like I told you, I've got the resource pages here, got some of the articles, some of the different ARC stuff and places where you can register for the different programs. And then a couple of resources here. There's an audit tool, some OR rounding checklists, and then even a gap analysis tool if you want to use those and tweak them for your facility. Here's all our contact information for the quality department at KHA. And then now we have about 10 minutes for questions if anybody has anything. And I can't see the chat yet, so I don't know if there's anything in there. You can unmute yourself if you have a verbal question.
Rochelle, this is Tammy. We had one question in the chat box early in your presentation. It was a clarifying question. If the colon surgery is emergent, contaminated, and dirty, does NHSN count that infection against the hospital?
So a colon case is always going to be clean contaminated. It can never be clean. So that's just the way it's going to be always.
And I think if you're asking if the fact that it's emergent and maybe you don't do everything you do on a normal situation, does it still count? It does. There is a place on NHSN where you're marking emergency. So that is, one of the elements that is counted, but you still have to enter it.
I see a question from someone in the chat about a % for iodine-based surgical hand scrub for a surgeon who has an allergy to CHG. Off the top of my head, I don't know what the specific one would be. They did reference a 5 to 10 for the nasal decolonization, but I will get back to you on that and let you know, Nita.
While people are thinking of questions, first of all, I just want to say, Rochelle, you did an excellent job. This was a wonderful presentation, very complete, lots of things to think about. And as I put in the chat, as we go forward with our QI work here at KHA, we're going to be focusing a lot more than we have in the past on the process measures. Obviously, the outcomes are important. That's what we're going for, but we're going to talk more about processes, what you're collecting, what those results of your collection of those the measures data look like, and then some help with folks who might benefit from that with some, QI advice or consultation for you all, because sometimes you can be the most educated SSI person in the world, but sometimes an outside set of eyes really is useful. Just sometimes you see something that we all in our own environments don't see because we see it every day. So we'll be reaching out to people as we look at people's rates as we go forward. So I just did want to mention that, but I don't want to get in the way of the questions. If there are more questions, we can go back to that. Natasha's asking about physician engagement. And I'll just put in a plug here. We can, that is a great topic, and we can actually get really into that topic on a webinar for all of the different harm areas. But one thing that if people are not familiar with ISCR, that is, first of all, Rochelle will write down physician engagement as a topic for a webinar, because I think that's a great idea, Natasha. But I was going to say, if you're not familiar with ISCR, it's free. And one of the things that ISCR saw over time is that because the American College of Surgeons was a co-administrator, co-sponsor, and participated so heavily in it, much more physician engagement in that, both anesthesia and surgeons, because as we all know, docs like to talk to docs. And so no disrespect to us, hopefully, but it's just that's what they're used to. It's what they prefer. And so having an initiative that's very heavily physician and nurse together oriented was really useful for these folks. So we'll definitely continue to give you information about ISCR if you're interested, but in the meantime, we can do a lot to help with that as well. I think we have a lot of physician engagement from CMOs. So perhaps we can use that to help with your physician engagement in your ORs and elsewhere. I can't see the chat, so if someone could help with that, that'd be great.
Let's see.
I see them when they pop up, but then I can't. Then they go away, so I can't.
Yes, the recording will be available and the slides. It should go out, if not in tomorrow's newsletter, at least in next week's newsletter. Is that correct? And then someone again asking on emergent colon cases where the patient comes in with a perf colon, ends up being a class 4. Do these cases count against the hospital? Like Deb had mentioned, in the status of emergent cases, they're still reported into NHSN, and unless they fall out on the specifics on like a super long case or the different components within NHSN, they will still be counted in the numbers. NHSN, these are all, we have to remember, these are all surveillance definitions, and that we keep the surveillance definitions within NHSN so we can get accurate reporting numbers. So they're still gonna be the same, and sometimes we'll like it and sometimes we won't, and sometimes it'll fit perfectly and sometimes it won't, but that is just kind of the nature of the surveillance tracking. And we can have an NHSN whole discussion, a whole other webinar that could last probably way longer than an hour, but we can also have that as well, and we can set up chats to talk about NHSN too.
That's a great idea. For some reason, when I'm, even if I can see the chat, if I try to reply to everyone, it's just going to Tammy. So there's a question in the chat that says, do I have information on the new studies for alcohol-based nasal decolonization? And I do have that. If maybe when we place the link to the recording and the slides in the update, we can include that information, if it's okay with you, Rochelle.
Yeah.
And also, if anybody wants to email me separately, or Rochelle separately too, we will be happy to provide you with that.
All right, unless I'm not seeing anything coming through. If anyone has any questions they want to ask verbally, you can. Otherwise, we will let you guys go. Thanks for joining.
Thanks
and
very
it's nice
much,
to
everybody.
meet everybody, quote unquote.
Thanks, everybody.
Thank you.